Hello, my name is Sue Fraze. I am one of the nurses that works on 4B, the orthopedic unit, where you will be cared for following your knee surgery. We have found that patients who know what to expect with regard to this surgery have a much better experience. The purpose of this video is to provide that knowledge and to reflect the way we do things on 4B. After the video, we will talk about some of the routines and procedures related to total knee arthroplasties. If you have any questions, please ask your nurse after the video. The first thing you will notice when you wake up in recovery is that you are receiving oxygen through a small tube called a nasal cannula. We will leave this on until the morning after your surgery. Then we will check your oxygen saturation with a small probe attached to your finger. If the level is adequate, we will discontinue the oxygen. If it isn't, we will leave the oxygen on and recheck your saturation level at a later time. You will have a bulky dressing extending from your mid-thigh to the middle of your calf. This is called a hemovac. You may notice it either clipped to your gown or lying on your bed. The ends of the hemovac are inserted near the wound just before the doctor stitches or sutures the area. It works by negative pressure, sucking out any excess drainage that occurs after the wound is closed. The hemovac helps ease pain by reducing edema or swelling. It also aids in removing old blood which could clot or begin to cause an infection. We empty the hemovac at the end of each shift and record the amount obtained in your chart. Usually on the second post-op day, the hemovac is removed and a smaller, lighter dressing is applied to your knee. Because of this strain, we suggest that you wear the hospital gown for at least the first 3 days of your stay, until the drain is out and the drainage has stopped. After that, you may wear your own pajamas or gown if you like. You may feel something squeezing your legs. These are called Flotrons and fit around your calves. They have a bladder which fills with air from a machine which is hanging at the end of your bed. Because of your immobility, blood could lie in your calves and possibly clot. The Flotron's purpose is to help push the blood back toward your heart and decrease your chance of a blood clot. When you are in bed, these should always be on your legs and the machine turned on. In addition to the Flotrons, you may also have white surgical hose on your legs. Their purpose is also blood clot prevention. The hose should be on at all times and only taken off when you take your bath. You will have 2 pairs so that we can change them daily. If you have these during your hospitalization, you will probably be expected to wear them at home for several weeks after your discharge. You will also be given an anticoagulant to decrease the chance of a blood clot. It might be in the form of a shot called Lovenox, which you would receive twice a day, or in pill form called Coumadin, administered once a day. If you receive the pill, you might have your blood drawn each morning to measure your bleeding time. Your Coumadin dosage will be regulated according to your clotting times. Sometimes patients continue to take Coumadin at home after their discharge. If you are required to do this, we will make arrangements to continue drawing blood so your doctor can keep you on the correct dosage of Coumadin. Between the nurses checking the circulation in your legs, asking you to pump or rotate your ankles, looking for signs of a blood clot, and using the surgical hose, Flotrons, and anticoagulants, your chance of a blood clot is very small. In addition to drawing your blood to monitor your bleeding time, we will also monitor your blood count. This is usually checked for the first 3 days after surgery. If your blood count drops too low, your doctor may suggest a blood transfusion. If you have donated blood prior to your surgery, you will most likely receive it back. You may be required to use an incentive spirometer. Its purpose is to help you fully expand your lungs and decrease your chance of acquiring pneumonia. Your nurse may ask you to take 10 deep breaths every hour with the incentive spirometer while you are awake. The nurses will also ask you to cough and deep breathe. Taking deep breaths with the incentive spirometer may make you cough as well. You will be turned every 2 to 4 hours after surgery while you are in bed. This will promote comfort and also decrease your chance of developing pneumonia and skin breakdown. You will have intravenous fluids infusing when you wake up in recovery. We will keep these fluids infusing until you are able to take fluids orally without being nauseated. Your blood pressure is stable, your bowels are active, and your body is making urine. The IV fluids are usually discontinued the day after surgery. You will need IV antibiotics post-operatively. Everyone needs them. They are a preventive measure against infection. The first one is given in the operating room, and subsequent doses are given every 8 hours, usually for a total of 6 doses. If your continuous fluids are stopped, we will keep the IV access in your arm or hand to administer the antibiotics. Once your antibiotics are completed, we will discontinue the IV. Once you have been evaluated in post-op and it is determined that your bowel sounds are present and you are not nauseous, we will start you on a clear liquid diet, which will progress back to normal as you can tolerate it. Most orthopedic patients do not have a bowel movement for the first few days after surgery. This is not unusual. If after the first couple of days post-op you begin to feel uncomfortable, we can ask the doctor to order a stool softener or a laxative to help you. Patients also worry about using the bedpan after surgery. Once you have an order to get up in the chair, you can use a commode at the bedside for toileting. Some patients have difficulty urinating after surgery. If you have this problem, we can contact the doctor for orders to straight cath you. We'll use a straight cath because other catheters can increase your chances of a urinary tract infection. You must be very careful now about infections. Your new knee needs to be protected. It is foreign to your body, and the first place an infection could go, if you get one, is to your knee. This chance of infection also applies to your health. From now on, whenever you need any dental work or surgery, you must tell your dentist and/or doctors about your total knee so antibiotics can be ordered to prevent infection. You also need to know that your new knee may set off metal detectors in airports or retail stores. At your request, your doctor can arrange for an ID card which shows you have a metallic implant. The day of surgery, patients remain in bed. Usually the morning after surgery, you will get up in the chair for the first time. That afternoon, you will go to physical therapy. The first time in therapy, you usually stand between the parallel bars, and the physical therapist helps you determine your weight-bearing status. The next day, you will go to physical therapy twice, in the morning and again in the afternoon. You will probably begin walking with crutches or the walker at the discretion of your therapist. Part of your physical therapy is also sitting up in the chair. There are 2 therapy sessions each weekday with a morning session only on Saturdays and Sundays. Your doctor may also have you use the passive motion machine or the CPM. This machine flexes and extends your knee. It prevents your knee from becoming stiff and helps reduce scar tissue at your incision site. The machine's setting is predetermined by the doctor and increased about 10 degrees each day to a total of 90 degrees. Your doctor wants you to use the CPM machine a minimum of 8 hours a day. Most patients wonder how 8 hours a day is possible with 2 therapy sessions a day also. You will be busy, but remember that recovery is work as well as rest. I usually suggest that you ask to be placed in the CPM around 5:30 or 6 o'clock in the morning. Breakfast is served around 7:30 a.m. Ask your nurse for some pain medication with your breakfast. Therapy will begin between 8 and 8:30. By that time, your knee will be less stiff, your pain medication will be peaking, and you can get the most out of your therapy session. If you go back to bed after therapy, ask to be put in the CPM again. At lunchtime, ask for pain medication again. When it is time for afternoon therapy, the medication will again be at its peak, and you will have a good therapy session. You might request pain medication again with your supper. After supper, get back in the CPM until around 10 or 10:30 p.m. Then request that it be removed, get turned on your side, and get a good night's sleep so you will be well rested for the next day's workout. Some patients like to stay in the CPM all night, and that's okay, but you need to rest your back by turning on your side occasionally. You will attend occupational therapy, where therapists will help you learn how to perform and practice activities of daily living, like dressing, toileting, and getting in and out of bed. You should bring a robe to wear in therapy, as well as shoes or slippers that are comfortable, supportive, and provide good traction to prevent you from slipping or falling. The therapy rooms are located at the end of the unit on 4B. You may spend time at Independence Square learning to get into and out of the car and practicing other activities of daily living in the apartment there. Therapists at Independence Square will expose you to situations which you would ordinarily be exposed to in your everyday life. The therapists will not release you from therapy until they are confident that you are independent and able to perform daily living activities on your own. Many insurance companies limit the time you can stay in the hospital after your surgery. If your doctor feels you need more therapy, he or she may suggest that you go to our Ready to Go home. At that time, the therapist can assist you in obtaining any devices which you may need at home, like a walker, crutches, stool riser, or sock donner. Finally, we should discuss pain. Our goal is that your pain decreases each day you are with us. Post-operatively, the doctors usually order shots and pills for pain control. The nurses are very good at keeping you medicated the first 24 hours or so. After that, we request that you let us know when you need something for pain. Once you are able to do without the shots, you can switch to pain pills. At Memorial, we use a pain scale. It ranges from 0, which is no pain, to 10, which is the worst pain you have ever experienced. The nurses will ask you to identify an acceptable level of pain based on that scale. Each time you request something for pain, the nurses will ask you to rate your pain. This helps us monitor your pain to determine proper medication dosages, how often they are given, and other possible adjustments or additions to your regimen. To aid in the care you'll receive on 4B and in therapy, we want to stress the importance of self-motivation. The more you work at recovery, the sooner you'll be able to go home. The average length of stay is about 5 days.